là cả các chuyên gia về miễn dịch thần kinh tại trung tâm quốc gia về khoa học thần kinh của Singapore, thì chúng ta sẽ nghe bài về tối ưu hóa điều trị xơ cứng rải rác dựa trên các thuốc điều chỉnh diễn tiến bệnh sẵn có. Xin mời tiến sĩ Trên.
Yeah, good morning, everyone. Yeah, thank you for, I'd like to thank Merck and the organizers for the invitation for today's morning talk. Okay, so I'll be talking a little bit about optimizing MS treatment based on the available disease-modifying therapies, or DMT. My name is Jean. I'm in the neurology department of the National Neuroscience Institute in Singapore. These are my disclaimers. The information included in this webinar is solely for educational purposes and not intended to promote the use of any products. And the content of this presentation was developed by me, and Merck has no influence or responsibility for the content of the presentation. And these are my disclosures. I received honorarium from Merck for speakers' fees, research grant from the NMRC Singapore, as well as NNI, and I also have travel grants from AstraZeneca, Merck, and Roche. So before I touched on the treatment for MS, I would like to also touch a little bit on the recent changes made to the McDonald's diagnostic criteria. So for the diagnosis of multiple sclerosis, in the 2017 McDonald's criteria, we require 2 clinical attacks as well as objective evidence of 2 lesions, otherwise known as DIT and DIS criteria. And there can be different combinations used to achieve the criteria for MS diagnosis. In the 2024 proposed changes to the criteria, which was presented in ACTRIMS 2024, and we are still pending the formalized publication for the proposed changes, basically these are the proposed changes. Okay, which is radiological isolated syndrome in MS is MS in specific situation, optic nerve asophysis topography, DIT is no longer needed, updated in the DIS criteria, kappa-free lumbar chains as a tool for diagnosis, and the same criteria is used for PPMS and RMS diagnosis, as well as the need for paraclinical evidence to diagnose MS. And to increase the specificity, there's more strict features for confirming the diagnosis in individuals over 50 years old or headache disorders or vascular disorders patient. And then the use of central vein signs and paramagnetic rim lesions as an additional tool to increase the specificity of the proposed criteria. And in children and adolescents, additional laboratory tests such as the MOC antibody is required to exclude other diagnoses. So we look at the specific changes per se in brief. So for RIS, we know that in 10 years, there is a 51% risk of RIS developing to clinical MS, and this percent increase with other factors such as young age, typical lesions, as well as oligoclonal positive. As such, for the 2024 revisions to the McDonald criteria, RIS is identified as an incidental discovery of CNS white matter T2 weighted hyperintense foci on the MRI that is highly typical of MS, but without clinical symptomatology. And the recommendation made is that in patients with RIS, fulfilling DIS and DIT is sufficient to diagnose MS. And if you don't have DIT, you can fulfill DIS with oligoconoband is sufficient to diagnose MS. And for RS, fulfilling DIS, the presence of more than 6 central vein signs is sufficient for MS diagnosis. Next, we'll look at the other 5 proposed changes, and these 5 changes are actually proposed to help areas or regions with no easy access to MRI and to allow additional criteria or other factors to help diagnosis for MS. So one of the major changes is that of the use of optic nerve as a 5th anatomical location to demonstrate DIS if no better explanation exists for the optic nerve pathology. So we can also use it on short typical lesions that is seen on MRI to demonstrate as evidence of optic nerve involvement. We can also use visual evoked potential as a means of evidence of optic nerve involvement, as well as abnormal OCT to serve as evidence of optic nerve involvement, and this will demonstrate as DIS or MS criteria diagnosis. Other things that we want to look at that is in the 2024 revision is that of disseminated in space. So they recommend that DIS is fulfilled by 2 out of 5 topographies, which includes the optic nerve, juxtacortical, optical, paraventricular, infratemporal, and spinal cord lesions. And when these show typical lesions, regardless of whether these lesions are symptomatic, DIS is fulfilled. And again, as per the 2017 criteria, fulfillment of DIS and DIT is sufficient to diagnose MS. We can also use the DIS with oligoclonal positive or kappa-free light chain in the CSF to diagnose MS. No need for DIT. Okay, so this is something that is different from the 2017 McDonald's criteria. And in patients with typical symptoms and typical lesions in 4 topographies is sufficient to diagnose MS. Patient with typical symptoms and typical lesion in 1 topography, presence of 6 central vein signs or paramagnetic lesions plus DIT or CSF positive is sufficient to diagnose MS. And in progressive disease, 2 spinal cord lesions are sufficient to demonstrate DIS. So for kappa-free light chains, previous study has already shown that kappa-free light chains appears to be specific in MS patients as well as the CIS and RIS patient. This kappa-free light chain index is also increased in patients who are also in the subtype of MS, the SPMS and the PPMS. As such, the proposed criteria feels that there is a kappa-free light chain is an appropriate paraclinical test for the diagnosis of MS and can be used interchangeably with oligoclonal band. Next, we will go on to the next few criteria, which is aimed to increase the specificity of the McDonald's criteria. So one of which is that of the central vein sign, which is defined as the presence of a central vein, as per the name suggests, within a T2 image. And there are specific radiological criteria to define the central vein, but essentially, central vein signs have been shown to demonstrate to be specific for the diagnosis of MS, and also the number of central vein, the highest specificity or positive predictive value is highest with 6 central vein signs. So as such, the recommendation is that in patients with typical symptoms and DIS, the presence of the rule of 6 central vein sign lesions is sufficient for the diagnosis of MS. And in patients with typical symptoms and typical lesions in 1 topography, the presence of 6 central vein sign plus DIT or CSF positive is sufficient to diagnose MS. The other lesion that is proposed to be in the 2024 revision criteria is that of paramagnetic rim lesion, And these are iron deposits around the MS T2 hyperintense lesions. And this is suggestive of chronic inflammation. So in this study, where they look at the systemic vasculitis versus multiple sclerosis brain imaging, you can see that with the T2 lesion, hyperintense lesion, the paramagnetic rim lesion is absent in the systemic vasculitis patient, but is present in the MS patient. And as such, if the committee recommends that the demonstration of PRLs by MRI can increase the specificity of the diagnosis in MS. So in patients with typical symptoms and typical lesion in one topography, the presence of more than one a paramagnetic rim lesion plus DIT or CSF positive is sufficient to diagnose MS. So in summary, if you have a patient with signs and symptoms suggestive of MS, an initial workup is suggestive, including the medical history, clinical examination, imaging and laboratory tests, and differential diagnosis is sufficiently excluded. With lesion in more than 2 CNS topographies or progression in patient, 12-month progression in patient with 2 spinal cord lesion, multiple sclerosis can be diagnosed if one or more of the following are demonstrated, such as CSF positive, the central vein sign positive, disseminated in time, or lesions present in 4 or 5 CNS topographies. Now, if, let's say, the lesions are only present in 1 CNS topography, then MS may be diagnosed if one or more of the following is demonstrated, which can be CSF positive with central vein sign or paramagnetic rim lesion, or disseminated in time with CVS, or disseminated in time with PRL. For the RIS patients, where incidental imaging is suggestive of demyelinating disease, again, looking at the medical history and clinical examination, imaging and laboratory tests, and exclusion of required differential diagnosis, if the lesions are present in more than 2 CNS topographies, MS may be diagnosed if one of the following are demonstrated, such as CSF positive, central vein sign positive, and disseminated in time. In addition to that, for the 2024 revision of the McDonald's criteria, there's a specific mention that in patients who are considered for diagnosis of MS above the age of 50, with or without vascular risk factors such as hypertension, smoking, diabetes, hyperlipidemia, or known vascular disease or headache disorders, additional features are strongly recommended to confirm the diagnosis of MS, which can include a spinal cord lesion, a positive CSF, and the 6th central vein sign. And for the pediatric population, pediatric and adult onset MS can be diagnosed using the single diagnostic criteria framework in patients with ADEM presenting with a second clinical attack, consistent with a typical MS attack, with T2 lesions in a typical MS topography, more than 90 days post-ADEM onset is required before MS diagnosis can be applied. And the recommendation is again the presence of central vein sign in approximately 50% of the T2 lesion. Mock testing should be done and strongly recommended in patients who are less than 12 years old. In patients who are more than 12 years old or equals to 12 years old, mock testing is advocated in the context of atypical presentation for MS. So next, I'll move on to DMT in MS treatment. So when we look at the DMT available for MS treatment, the current DMTs are divided grossly into highly effective treatment and moderately effective treatment. And these are the distribution of the DMTs available with the safety profile. So as you can see, the lower or rather moderate effective treatment have higher safety profile compared to the higher effective treatment. And regardless of whether it's higher efficacy or moderate efficacy, most of the DMTs, in fact all the DMTs, show that there is a reduction in annualized reduction rate compared to placebo. It's just in terms of the effectiveness. So then we'll move on to the efficacy outcome of cladribine. So cladribine efficacy was studied in the CLARITY trial, and the design of the CLARITY trial was that of using 1,326 patients randomized into 3 arms, known as the placebo arm, cladribine at a 3.5 milligram per kg dose, and cladribine at a 5.25 milligram per kg dose, or what we call the higher dose. And they assess the patients with MRI at regular intervals 3 times in year 1 and then at the end of year 2. And the CLARITY endpoint was that of annualized reduction rate at year 2, and secondary endpoints include the proportion of patient relapse-free interval, time to 3-month confirmed disability progression, the mean T1 gadolinium positive at year 2, mean T2 lesions at year 2, and the mean combined unique active lesion at year 2. So you can see that the primary endpoint is met because the annualized relapse rate was shown to have a 58 relative reduction in patient receiving cladribine at the low dose of 3.5 milligrams per kg compared to placebo. And there is sustained relapse-free interval in patients having the cladribine tablets at 3.5 milligrams per kg dose compared to placebo. In addition to that, cladribine has shown to reduce the annualized relapse rate at a post-hoc analysis even at week 24, and this reduction is sustained throughout 2 years. And the T1 gadolinium positive lesions, as well as the active T2 lesions and the CUA lesions, were already reduced at week 24 and sustained throughout the 96-week study. There is also reduced requirement of corticosteroids and hospitalization with an overall reduction risk of 58%. So there is 59 risk reduction for corticosteroids requirement, 59% risk reduction for hospitalization, and in the actual reduction percentage, that is basically a half percentage of the patient with cladribine at 3.5 milligram per kg requiring corticosteroids for relapse during the CLARITY trial compared to placebo. In addition to that, they also look at the cladribine versus placebo, and there's a 47% reduction in the 6 months risk of EDSS progression at 2 years. So the treatment of cladribine also reduced the MRI lesions versus placebo at 2 years. This is seen by looking at the T1 gadolinium positive lesions. There's an 86% relative reduction of placebo compared to cladribine. Active T2 lesions, there is a 73% relative reduction of placebo compared to cladribine. And this also translates into percentage of brain volume change, whereby cladribine patients who are receiving cladribine, the arm receiving cladribine at 3.5 milligram per kg, so shows a reduced rate of brain atrophy compared to placebo. And this is also shown with the annualized brain volume change. So the cladribine arm shows a lower reduction of brain volume change compared to placebo. And looking at the NIDA-3 status, which is defined as patients who are relapse-free free of active T2 lesions, free of EDSS progression in 6 months, and free of gadolinium lesion presence. There is actually a 47% percentage of patients achieving NIDA-3 compared to placebo, which is 17, which is a 3 times increase. And again, when they look at throughout at week 24, week 48, and week 96, there are significantly more patients achieving NIDA-3 status for the cladribine arm compared to the placebo arm. Next, we would like to also look at the safety profile of cladribine over a prolonged period. So with the Clarity patients, after receiving the appropriate arm treatment, there is a bridging interval. This bridging interval is variable according to the recruitment site. Then the patients are then again divided into the different arms. For the placebo group, they went on to receive cladribine. And at this point, because of the adverse events noted in the initial Clarity trial, the dosage taken was that of 3.5 milligram per kg. And you can see that the cladribine patients that has received placebo and then subsequently cladribine is otherwise known as the PC group. Then look at this part where the cladribine arm receiving 3.5 milligram per kg is then randomized into placebo and cladribine at 3.5 milligram per kg continued intake. So it's the CP group and the CC group. Okay, these are the few groups that we will focus. And of course, the high dose cladribine was also randomized into the placebo and cladribine arm. Okay, so the Clarity Extend is mainly to see the safety profile as well as the extended efficacy for cladribine. With that, they look at the endpoints of lymphopenia, which is a common side effect, as well as patients with adverse events and serious adverse events, okay, which is defined as lymphopenia, infection, neoplasm, and death. And then medium time to recovery from grade 3 or 4 lymphopenia, proportion of herpes zoster infection and malignancy, annualized qualifying relapse rate, number of T2 gadolinium positive lesion, and time to disability progression. So if we were to see, basically the arm that had cladribine and followed by placebo, or patients who had cladribine first and then followed by additional cladribine dosing, the time to 3-month progression for EDSS progression does not differ. So less than 30% of the patient reached 3 or 6 months confirmed EDS progression at 5 years. They also look at if you have cladribine earlier compared to a delayed cladribine tablet in consumption, there is basically disability improvement by EDSS or higher or earlier cladribine intake compared to those with delayed cladribine intake. So improvement again is defined as EDSS score changes more than 1 point from baseline if the EDSS score is less than 5.5 or more than 0.5 at baseline or EDSS score more than 5.5. And 2 years after starting cladribine, 21.3% of the patient who was treated early has sustained EDSS improvement, and 15% maintained this for up to 5 years after starting treatment. And delaying cladribine 2 or more years reduce the prevalence of patients to improve and sustain improvement over time. And looking at the safety profile, because remembering that the objective of cladribine Extend was to assess the safety profile following further treatment of cladribine. For patients who had received cladribine first and followed by placebo, all adverse events was seen in about 75.5% of the patient. Serious adverse events in 16.3%, adverse events such as lymphopenia leading to discontinuation, was 0, but adverse events leading to treatment continuation was 3.1%. And in the delayed group, okay, it's actually slightly low, it's variable as well and not significantly different. And these are the top 10 frequently reported adverse events with cladribine, with lymphopenia being the highest. With lymphopenia being the most significant. So with that, okay, the current cladribine protocol is that of having a year 1 and year 2 dosing, of which you get your first week dose, month 1, week 1 dose over 4 to 5 days, and then month 2, week 1 over 4 to 5 days, and then at year 2 you repeat. Okay, subsequently we observe. And again, this is based on the patient weight at 3.5 milligrams per kg over 2 years. Okay, so in summary, in patients with active RRMS during the Clarity trial, okay, when we compare cladribine versus placebo, there is a reduction in ARR, increase in relapse-free rate, reduction in 3 and 6 months sustained progression of disability, reduction in brain lesion count, and this is consistent in terms of benefit across the patient subgroup, including patients with high disease activity. For the Clarity Extend trial, basically to confirm the treatment effect and also to look at the safety profile of cladribine tablets. ARR and disability progression was similar across treatment groups. The treatment of cladribine at 3.5 milligram per kg in Clarity trial had a sustained effect on MRI outcomes in majority of the patient. And this effect is sustained in patients who were treated with placebo in the Clarity Extend. And the residual MRI activity was limited in patients with the longest time of active treatment. So next, I will move on with our practical experience of cladribine in patients in Singapore at NNI. NNI essentially sees about 2/3 of the Singapore MS patient cohort, and we have availability of different DMTs as mentioned in the table prior, and it's at different timings of approval. So of course, the interferon were the earliest, and then moving towards the higher efficacy subsequently. Cladribine was approved for use in Singapore in 2019. So this is based on the 2024 clinical audit, whereby we look at the DMT treatment for all patients with active follow-up. We have 206 MS patients on active follow-up, meaning at least for 2 years they come for clinical examination and in clinical review. And we have a large proportion of patients, okay, on DMTs, which is about 81%, and about 19% made a choice not to be on any DMT. And of the different DMTs, these are the different ones. We have 35 patients currently on cladribine, and then we have 84 on the B-cell therapies, and then the various numbers accordingly. So to give a brief background, okay, cladribine was approved in Singapore for RMS treatment, okay, in May 2019. And in August 2019, the first patient was treated in NNI. And then as of previous 2024 audit, we have 42 patients treated with cladribine. And the monitoring plan for MS treatment is the same as highlighted previously. Basically, we give the patient cladribine according to their weight at 3.5 milligram per kg over 2 years. Okay, so it's month 1, week 1, month 2, week 1 in the first year, and then month 1, week 1, month 2, week 1 in the second year. And then we will monitor the bloods at month 3 and month 11 accordingly, looking specifically also at whether or not there's lymphopenia, and the decision will then affect the dosing, the timing of the dose of the second year cladribine. and we follow the recommended guidelines, okay, we will treat with cladribine when the lymphocytes are more than 0.8 times 10 to the power 9 level. And we do a re-baseline brain imaging at about 3 to 6 months, okay, after the initiation of cladribine during their year 1. And if we do see that there is low lymphocyte count, we will look at the whole blood count again at 6 months interval. At year 2, we will check the full blood count and liver panel at month 3, and then we'll go clinically and observe. Thereafter, we will perform brain imaging at a yearly interval if stable. So this is a profile of the cladribine treated patients in NNI, 35 on active follow-up, and essentially some of them we have switched from previous DMTs and some of them are naive. We see a dip in 2020-2021 due to COVID, but generally we try to involve the patient early in the decision making, and it's a patient choice. We also look at the patients who have received the full dose of cladribine and following on in their year 3, year 4, and year 5. How are they performing? So we have 27 patients who received the full dose in year 3 to year 5. 1 transferred care back to Europe, and then 9 had clinical activity. Okay, of the 9 that had clinical activity, 6 had a clinical relapse and radiological activity. 3 had radiological activity. And of these 9, 5 switched to B-cell therapy. 1 opted for a 3rd dose of cladribine and has been stable. Another opted at a 3rd dose of cladribine with a clinical relapse at year 4 and then made a decision to switch to B-cell therapy. And the remaining 2 opted for close monitoring. So this again shows the profile of our patients, okay, on cladribine beyond year 2, so in year 3 and year 4. And you can see that these are the relapse cases that I have mentioned just now in summary, and the rest with no relapse on clinical monitoring. So this is just a case study of one of our first patients who was started on cladribine. She's a 27-year-old Chinese female who had presented with bilateral lower limb paresthesia in October 2018. MRI shows a T8 non-enhancing lesion. MRI brain shows white matter lesions with faint enhancement. CSF oligoclonal was positive, and she was diagnosed with RRMS and was given IV steroids and recovered. She was followed up in clinic, and at that point, she was waiting for cladribine to be approved. And upon approval, we started her on cladribine. In her end of year 1 MRI scan, there was no new lesions. Here's the flare image. When she was reviewed again in clinic, again we repeated the MRI, and this time there's a midbrain lesion. New tiny one over here on the right side. No pathological enhancement. Discussion was set to watch for now. And in October 2022, there is a new white matter lesion in the right temporal and the right septum semiovale with no pathological enhancement. She made a decision then to continue for clinical observation. And the last that we reviewed her before she relocated, she was clinically stable. With that, I thank you for your attention, and it's open for any questions. Thank you.